Welcome you all to our first class of our 9th batch of Secrets Unveiled Basis. Myself, Dr. Otonude, I will guide you through the session. So, before starting the session, let me give you some idea of the BASIS clinical exam. Actually, this exam comprises 5 stations. Station 1, Station 2, Station 3, 4, and 5. Among all the 5 stations, the most 2 important stations are clinical consultation, that is Station 2 and Station 5. And this course is solely on the full preparation of the clinical consultation. So before I start, let me make it clear that am I audible to every doctors? Is it clear, doctors? Okay.
Yeah.
So during our consultation, if anyone have any kind of confusion or any question, please feel free to stop me at that time, because this course will be a little bit interactive. So let me first give you the idea of this course. So here, Station 2 and Station 5. These 2 stations comprises the long clinical consultation, which in short we call it LCC. And these 2 stations are the most important stations if we want to pass the MRCP BASIS clinical exam. The importance of these 2 stations is so much so that if it is said to be, said that if anyone gets full mark in long clinical consultation and both the communication stations, it is really very much difficult for any candidate to fail. That is why our target of this course will be to make you fully prepared for this long clinical consultation. That is Station 2 and Station 5. So let's progress. So in this course, we'll try to approach with prompt. So what is prompt? Prompt is the given symptom that is given outside the station of Station 2 and Station 5. Like there are so many prompts like blood in the urine, low back pain, knee pain, fever, and swallowing difficulty. And there are lots of prompts. There are endless prompts. But there's a particular pattern for the BASIS examination. If anyone notice the prompts that comes in the last 4 years, you will be able to make it identify that what specific prompts comes in the BASIS exam. And we have identified a total of 73 prompts. Among the prompts, we have divided the prompts according to each system, like the musculoskeletal, neurology, GIT, CVS. According to each system, we have divided the prompts. Not only that, on top of that, the prompts have been divided according to importance. Like today, we're going to discuss the musculoskeletal system prompts. These are the musculoskeletal system prompts. Here, we have divided them according to importance, like triple star prompts, then double star, then 1 star. Triple star prompt means these are the most important one, and they have come multiple times in the BASIS exam. If it is possible, you can have a look at the past 4 years BASIS cases. You will be able to see that these triple star prompts come every now and then. So what we do in this course? First, we teach or we discuss how to take history for individual prompt. Like if the handpin comes in the BASIS exam, how to take the history, what are the important differential diagnoses we have to think, and how to rule out each differential diagnosis, what should be the screening question. We will give you an organized form of prompts and organized form of differential diagnosis with the specific screening question for each of the differential diagnoses. All of this will be given to each candidate in the form of recording, and you have to make the notes of yourself. So this is our prompt approach. Right after discussing the prompt, we'll start practicing from these prompts. And we have a list of 250 cases, almost 250 cases that have come in the last 3.5 years. We'll provide these prompts with the cases with a separate recording where you will get the physical examination, investigation, and management for each of the cases separately to make you practice beforehand. And then you have to practice each other with a partner. And if anytime anyone is having any kind of confusion, please make me a knock at my WhatsApp. I will try to help you. And right at the second session, we'll start practicing from this musculoskeletal system. So basically the difference from other courses in this course is that we don't run in blind approach. First, we will try to make you teach how to take history for each particular prompt. Then from that particular prompt, how the case has come in the last 3 and 5 years, we'll provide you the cases. Not that we'll provide you the case beforehand to make you prepare. And then we'll start practicing. And we have to do a lot of practice. In this way, we'll try to cover 250 cases that are real cases in our 11 sessions. So this is all about this course. Now let me tell you another thing. Here also, let me tell you that this course is a one-time course. You need not to repeat this course anytime, even in the future. Why I'm telling this? Because in this course, I myself try my best to provide all the things possible to pass this LCC station. And every time you repeat, you will get this almost the same information. And this is my guarantee, or from my side, it is assurance that you will get the access up to you pass the exam. So another characteristics of this course is that here we try to make the candidate not only think like an examinee, also he has to think like an examiner, like how the examiner thinks, what the examiner expects from us. To make it understand, we have to realize how the marks are given. So this is the basis mark sheet for long clinical consultation. In this long clinical consultation, 7 skills are assessed. They are physical examination, identifying physical signs, clinical communication skills, differential diagnosis, clinical judgment, managing patient concern, and maintaining patient welfare. In this course, this mark sheet will be discussed many times. And also you have to practice providing mark each other using this mark sheet. Only after that you will understand how the examiners expect the mark, what they expect from us. So let me discuss it one again. So after entering the station, we will face 2 examiners. One examiner will receive us from the door by welcoming us, and another examiner will keep sitting at a chair. Each of the examiner will have this mark sheet at their hand. So this mark sheet will be, at the top of this mark sheet, the prompt will be written and with the diagnosis. Like the prompt is headache, and the diagnosis is meningitis. This will be written in this way. Then the examiner will watch at our performance and they will decide our mark. Let me discuss with you how the marks are given. But before discussing the mark sheet, let me discuss with you another conception. That is the CCCA. And during our whole course session, I want every doctors to make it perfect thinking that how the CCCA forms, how we can introduce this CCCA format into our examination, our history taking. So what does CCCA means? CCCA means 3C and 1A. 1C is for confirm the diagnosis. Another C is for find out the cause or trigger. Another C is find out the complication. And A goes for association. And all of this CCCA has to be find out from the history, physical examination, and investigation. Let me give an example. Suppose there is a very wonderful prompt, very common prompt in the PCS exam. The prompt is swallowing difficulty. Suppose our prompt is swallowing difficulty and our diagnosis is myasthenia gravis. So, how we can format this CCCA in our history, physical examination, and investigation. First, let's start from the history. From the history, we have to confirm our swallowing difficulty. Here, the swallowing difficulty of myasthenia gravis is a type of oropharyngeal dysphagia. We'll teach you what is oropharyngeal dysphagia during our discussion of GIT prompts and how to take the history of oropharyngeal dysphagia. Actually, this oropharyngeal dysphagia happens during the initiation of swallowing. So from the history, we have to confirm that this is a case of oropharyngeal dysphagia. Then we have to find out the cause of this oropharyngeal dysphagia. And the cause is here, myasthenia gravis. We have to ask the questions of myasthenia gravis in the history to find out the cause. Then we have to find out the complication of this oropharyngeal dysphagia and myasthenia gravis. And the complication of any dysphagia is aspiration pneumonia. Another complication of myasthenia gravis that has to be ruled out for every myasthenia gravis is respiratory failure. So these are the two complications we have to rule out. Then we have to find out the association. We all know that myasthenia gravis is an autoimmune disease. So we have to rule out other autoimmune association. And for ruling out autoimmune association, there is a mnemonic. The mnemonic is DET CPRMB. Let me tell you beforehand that in this course, we'll learn a lot of mnemonic. So what goes for DET CPRMB? Here D goes for diabetes, A goes for Addison's, T goes for thyroid, C goes for celiac disease, M goes for pernicious anemia, R goes for rheumatoid arthritis, M goes for myasthenia gravis, that is our case, and B goes for vitiligo. All of this association has to be ruled out from the history. So this is how, from the history, we have formatted the CCCA. First, we have to confirm our oropharyngeal dysphagia from the history. Then we have to find out the cause. To find out the cause, we have to ask all the questions of myasthenia gravis. And in this course, we'll give you the list of questions that has to be asked for myasthenia gravis. Then from the history, we have to rule out the complication. The complications are aspiration pneumonia and respiratory failure. We all know that in any case of pneumonia, the patient will have productive cough. So we have to ask that, do you have any cough? Do you produce any film? By asking this question, we are showing the examiner that we are ruling out aspiration pneumonia. Then we have to ask about the breathing difficulty, ruling out respiratory failure. Then for the association, we have to ask a screening question of DAT CPRMB. For diabetes, the screening question is polyuria polydipsia. We have to ask about increased thirst and increased water loss. For Addison's disease, we have to ask, do you think you feel dizzy standing from the sitting position? In the PACES exam, never ever you will get any positive findings here. But these questions are asked to show the examiner that we are ruling out the autoimmune association. To rule out the thyroid association, we have to ask about the weather preference. To rule out celiac disease, we have to ask about the bowel habit, or we have to ask about any loose motion. To rule out pernicious anemia, we have to ask, do you think you are getting pale day by day? For rheumatoid arthritis, is there any joint pain? The case is itself myasthenia gravis. To rule out vitiligo, we have to ask any skin rash. So this is how, from the history, CCCA format is formed for this specific prompt, that is swallowing difficulty. May I ask to the doctors if anyone has any kind of question from this history taking? If there is any question, you are please feel free to ask me, doctors.
Um, I had a question regarding the
Yes,
history of
doctor.
pernicious anemia.
Yes, doctor.
About the paleness.
Yes.
Is it a part of history, like whether he's getting pale by pale, or should I take
Yes,
history of
doctor.
fatigue, whether he's getting fatigue or not?
The skin question should be getting pale day by day. Fatigue is a vague term. We will all discuss the approach to fatigue for PCS exam. We'll discuss this in our endocrine session. But for this pernicious anemia, or for any kind of anemia, the screening question should be: do you think you are getting pale day by day? Believe me, in the PCS exam, you will never ever find any pernicious anemia for the myasthenia gravis. This thing has to be asked only to show the examiner that we are ruling out the association. And also, let me tell you another important thing for the sake of the examiner. That is, it is not part of this triple CA. The thing is, in the PCS exam, we are being assessed to enter at the register level. We are supposed to enter there as the ST3 level. So right after entering the ST3 level, we'll be given training for 4, ST4, 5, 6, 7, and 8. After completion of the training, sometimes 9 and 10 is also there. So we have to do the training in this long pathway. So after completion this whole year's training, we'll complete our CCT and will be declared as consultant. Why I'm discussing this conception? This is to be understood that this exam is not a super specialist exam. This is not a basic exam also. This is an exam to make us assessed to enter into the ST3 level. So that is why in the PCS exam, never ever we are given a case that is at a consultant level. The thing we have to ask to find out this particular pattern, I have to do the research for 4 years long. And every time you enter into the exam, every time you appear in the exam, before appearing in the exam, in the stations, a British examiner will come and tell you that we are keeping here the cases that you face in your day-to-day life at the ward setting. We are not putting some cases that are very much atypical. What is the purpose of telling this word? The purpose of telling this word is that they are not assessing us as a consultant there. They are assessing us whether we are a safe doctor working there as ST3 level. If you can make it understand, then this exam will become very much easy and doable for you. And believe me, this exam is very much doable. This is not that much difficult exam. This is a technical exam. In this exam, they assess whether we are safe doctors. They don't assess our knowledge level. They assess whether we are safe enough to manage the patient and also whether we are able to form the multidisciplinary team. We have to make the patient stabilized, and then we have to form a multidisciplinary team. We have to act there as a messenger. Our job will be there as a messenger. Like we have to receive the patient, we have to make stable the patient, then we have to form the multidisciplinary team, and we have to take the decision at that multidisciplinary team which member I have to include. That is why to pass the PCS exam, we don't have to read a lot of theory informations. Because already in part 1 and part 2, we have covered a lot of theory information. And the doctors who are taking the exam, they all already know this thing. They just assess where we are clinically safe doctors. And in this whole course pattern, you will make it understand. So, Dr. Saiful, is it clear to you how the triple CA has to be ruled out from the history, like for this prompt?
Yes, thank you.
Okay, thank you very much. So, from the history, we have ruled out the triple CA. Now, let's start for the physical examination. So, let's start the physical examination. So, there are two ways of doing physical examination. One is traditional. Another one is, sorry, this triple CA. So, what makes them different? The traditional way is that most of the candidates start doing from general examination, starting from the hand. Like we are going to rule out the anemia, clubbing, leukoplakia, tremor. So most of the examiner candidate start from hand, doing some general examination, looking for anemia, jaundice, or something like that. This is wonderful. Definitely, it is wonderful. But what happens sometimes in real exam, you may miss important part of your physical examination. So what makes this different in triple CA? If you try to follow this triple CA format, no important physical examination will be missed. Let me give you an example for this swallowing difficulty. Again, I'm telling you that, sorry, although there are triple CA, this triple CA will not be fit for every prompt. Like for every prompt, you will not be able to get all the components. Sometimes to find out the cause or trigger, there will be no physical examination. Sometimes to find out the cause or trigger, there will be no history. So we have to identify how the pattern gets fit. Let's discuss this prompt. So suppose the diagnosis is myasthenia gravis due to oropharyngeal dysphagia. Oropharyngeal dysphagia means the dysphagia happens before from the start of the swelling, and there will be nasal regurgitation, there will be coughing, choking, breathlessness. All these symptoms will be there. So, to confirm our diagnosis of oropharyngeal dysphagia, basically there is no physical examination. But to find out the cause of the oropharyngeal dysphagia, that is the myasthenia gravis, we have to do a lot of physical examination. And what are the steps of examination for myasthenia gravis? These will be given to you as a recorded form to all of the participants, especially the type 1 and type 2. We'll give you what are the steps of examination of myasthenia gravis. Sometimes we'll provide it in written format. Then to rule out the complication of oropharyngeal dysphagia and myasthenia gravis, already we have discussed. One is aspiration pneumonia. Another is respiratory failure. So, if the prompt is swallowing difficulty, to rule out the complication of swallowing difficulty, we have to auscultate the chest, looking for any crepitation there. In the real exam, you will never ever find any aspiration pneumonia crepitation. But we are doing the examination to show the examiner that we are ruling out aspiration pneumonia. To rule out respiratory failure, we have to offer bedside forced vital capacity. So this is how we have to rule out the complication. First, we have to do the physical examination to find out the cause. Then, to find out the complication, we have to do some physical examination. Then, ruling out the association, we have to do some examination. The mnemonic is DEAD CPR MV. To rule out diabetes and Addison's, we have to offer bedside blood sugar and sitting and standing blood pressure, looking for postural drop. Because in diabetes, the blood sugar will be higher. In Addison's, the blood sugar will be lower. So we have to offer bedside blood sugar and looking for sitting and standing blood pressure, ruling out postural drop. To rule out thyroid association, we have to check for neck swelling. We have to ask the patient, take a sip of water and swallow it and look for any neck swelling there. To rule, if there is, from the history, there is no history of loose motion, we don't have to do any physical examination. If to rule out pernicious anemia, we have to look for conjunctival pallor. If from the history there is no joint pain, we don't have to examine the joints. Then the case is itself myasthenia gravis. To rule out vitiligo, we have to look at the limbs of the patient and tell the examiner that we want to do full skin survey, ruling out any hypopigmented skin rash, that is vitiligo. Because some concealed area can be there, which has to offer. So in this way, from the physical examination, we have formatted the CCCA. You can look that if you go through the traditional way, starting from the general examination, sometimes you may forget to auscultate the chest looking for crepitation. Sometimes you might forget to offer the bedside force vital capacity. You may forget to rule out the association. But if you follow this CCCA format, you will not miss any important physical examination. So the choice is yours, which format you will choose. You are allowed to follow any type of format. But if you ask myself, I will suggest for this one. So may I know if this conception is clear to all the doctors? Any question from any doctors? Dr. Shifat, may I ask you if there is any question?
Yes, sir.
Yeah. Okay. Dr. Jahid, are you clear, doctor?
Yes, sir. No question.
Okay. So, doctor, if anyone has any kind of confusion, please stop me at that moment. And if it is clear, please give a thumbs up reaction so that I can make it understand that every doctor has make it understand. I am ready to repeat it 1,000 times until every doctors make it understand. So we have completed the physical examination. Let's go to the investigation now. In the investigation, also we have to follow this CCCA format. So suppose the case is swallowing difficulty. Due to myasthenia gravis, which is an oropharyngeal dysphagia. Also, it is called neurological dysphagia, whatever you term. So, to confirm our diagnosis of oropharyngeal dysphagia, apart from basic investigation, look at this particular line, that is apart from basic investigation, we have to mention for every investigation. That apart from basic investigation, to confirm our diagnosis of oropharyngeal dysphagia, we have to do the video fluoroscopy. Also, it is called video barium study. This is the examination, this is the investigation to confirm our diagnosis of oropharyngeal dysphagia. Then to find out the cause of this oropharyngeal dysphagia, we have to do the investigation of myasthenia gravis, like the anti-acetylcholinesterase antibody. If it is negative, then anti-mask antibody. We can also do the repetitive nerve conduction study, single fiber electromyography, and also CT scan of the chest ruling out thymoma. So these are the investigation to confirm our diagnosis. Then to rule out the complication, we have to do the chest X-ray. In the chest X-ray, ruling out any aspiration pneumonia or consolidation. We have to do the spirometry, ruling out any respiratory failure. Then for the association, the mnemonic is dead CPNMB for any autoimmune disease. We have to mention the investigation for each one. Like to rule out the diabetes, we have to do the fasting blood sugar and HbA1c. To rule out the additions, we have to do the 9 AM cortisol. To rule out thyroid association, we have to do the thyroid function test. To rule out the celiac disease, we have to do the celiac serology. To rule out the pernicious anemia, we have from the basic investigation, from the complete blood count, we have to look for anemia and increased MCV. To rule out the rheumatoid arthritis, we have to do the rheumatoid factor and NTCCP. Then to rule out the vitiligo, we have to do the full skin survey because vitiligo is a clinical diagnosis. And the approach to vitiligo, we'll discuss it in our dermatology session. Approach to any skin niche. So this is all how to tell the investigation. I'm again repeating. Suppose the case is swallowing difficulty due to myasthenia gravis. That is a case of oropharyngeal dysphagia. So in the investigation, we have to tell, apart from basic investigation, to confirm our diagnosis, we will do video fluoroscopy or video barium study to confirm the oropharyngeal dysphagia. Then to find out the cause, we have to do the anti-acetylcholinesterase antibody test or anti-mask antibody, repetitive nerve conduction study, single fiber electromyography, and CT scan of the chest. Then to find out the complication, we have to do chest X-ray, ruling out any aspiration pneumonia. We have to do the spirometry, ruling out the respiratory failure. And also for the association, we have to do this amount of test. If you tell in this way, never ever any examiner will cut any mark. And all the points will be touched. And all this investigation and management, like for each particular prompt and for each particular case, how the investigation has to be told, how the management has to be told, all will be given to each of the doctors for the type 1 and type 2 in recorded form. And you have to make the notes for yourself, doctor. So this is how we can format the investigation, CCCA in the investigation. Let me ask from the doctors if anyone has any kind of confusion about this CCCA. Because during our whole course session, this CCCA will come again and again, and this will help you. Any question from any doctors? Yes, doctor.
Yes.
Yes, please ask.
Can you repeat the investigation part?
Sorry, doctor. Can you again repeat? I missed the question, doctor.
Can you repeat just very quickly about the CCCA and the investigation?
Okay, I'm repeating it. Have you understood how to form it in the history and physical examination? Dr. Esra?
Yes, sir.
Okay.
Yes.
Let me tell it one again. So this is the investigation part. The case is same, that is swallowing difficulty due to myasthenia gravis. The myasthenia when we attend our GIT prompt session, we'll see how to approach to any swallowing difficulty. Basically, there are two types of swallowing difficulty. One is esophageal dysphagia, another one is oropharyngeal dysphagia. And myasthenia gravis is a case of oropharyngeal dysphagia. So, in the investigation, if we want to form this CCCA format, we have to tell, apart from basic investigation, to confirm our oropharyngeal dysphagia, we have to do video fluoroscopy. This is the investigation to confirm the oropharyngeal dysphagia. It is called video fluoroscopy. We can also call it video barium study. Then to find out the cause of this oropharyngeal dysphagia, the diagnosis here is myasthenia gravis. So we have to do the investigation for myasthenia gravis. And these are all the investigations for myasthenia gravis. Then to rule out the complication of any form of dysphagia is aspiration pneumonia. And another complication of myasthenia gravis itself is respiratory failure. So we have to do both investigation to rule out the aspiration pneumonia. Looking for consolidation, we have to do the chest X-ray. We have to do the spirometry, ruling out the respiratory failure. Because in myasthenia gravis, there is diaphragmatic failure there sometimes. And this is a very emergency. If it is there, we have to do the intubation instant. Then to rule out the association. Myasthenia gravis is an autoimmune disease. So any form of autoimmune disease, we have to rule out the other autoimmune association. The mnemonic is DATE CPR MV. So here D goes for diabetes, A goes for Addison's, T goes for thyroid, C goes for celiac disease, P goes for pernicious anemia, R goes for rheumatoid arthritis, M goes for myasthenia gravis. That is the case itself. And B goes for vitiligo. So we have to do the test for diabetes. That is fasting blood sugar and HbA1c. To rule out the Addison's disease, we have to do 9 AM cortisol. That is morning serum cortisol. To rule out the thyroid association, we have to do the thyroid function test. To rule out celiac disease, we have to do the celiac serology. That is anti-TTG antibody. To rule out pernicious anemia, first from the complete blood count, we have to rule out anemia. Then we have to proceed accordingly, like peripheral blood film and serum vitamin B12, red cell folate. To rule out the rheumatoid arthritis, we have to do the rheumatoid factor and anti-CCP. Then to rule out the vitiligo, we have to offer, vitiligo is a clinical diagnosis, so we have to offer full skin survey. And there is no investigation for vitiligo. It is a clinical diagnosis. We have to do the full skin survey to rule out vitiligo. This is all for investigation. Is it now clear, doctor?
Yes, very clear. Thank you.
Okay, doctor. There is another question from another doctor. How do we get the conclusion of myasthenia gravis to go ahead? Yes, doctor. How do we get to the conclusion of myasthenia gravis to go ahead with this format? Yes, all these things we'll get it. This is just initiation. How the myasthenia gravis case can be given in the PCS exam, you will get it during the whole course, because myasthenia gravis is a very much important case for PCS exam. And there is a particular pattern of PCS exam cases, like why this myasthenia gravis is very much important. Because myasthenia gravis case can be given in the neuro short case. So what they do in the PCS exam, like at one carousel, they will provide this case at the neuro short case. But at another day, with another carousel, they will again give this same patient at the long clinical consultation. At the long clinical consultation, for this myasthenia gravis, this case, the prompt can be swallowing difficulty. The prompt can be double vision or vision problem. The prompt can be fatigue. These are the types of prompt by how the myasthenia gravis can come in the PCS exam. And all the prompts will be discussed in our whole course. Not only that, the cases that has come up to now in the last 3.5 years, you will also get that case access. But you have to do the practice. First, you have to take the preparation. You have to take the preparation for that particular prompt and also for that particular case. Then you have to start doing the practice with the other participants. And then at the next session, I will do one-to-one session. I will do the one-to-one practice with each active candidate. I'll see how you have practiced before this, after this last session. That is why myasthenia gravis is very much important, because this case will be there at the neuro short case station. They can switch this case with long clinical consultation. Like this, like the myasthenia gravis, there are many other cases like the systemic sclerosis, which is given in the respiratory short case. But again, this case can be switched as a long clinical consultation. The prompt can be hand pain. The prompt can be breathlessness with dry cough. The prompt can be hypertension. There are particular types of case, like this one, systemic sclerosis and myasthenia gravis. And during this whole course, you will get an idea what are that particular cases, why these cases are very much important. Another case is Parkinson's disease. There are many other cases like this, because Parkinson's disease can be a short case. Also, it can be a long case in the form of hand tremor or walking difficulty. So we'll discuss it accordingly. Because in this course, I have tried to include all the things that is possible to come in the PCS exam. And this is my guarantee that in the PCS exam, there's a 90 to 95% chance of getting common exactly from these prompts. But there is a 5% chance of not coming common the cases. But how, if the case itself does not get common, you can complete the prompt history taking. And how it can be covered, you'll get it understand once this introduction is completed. So, Dr. Saiful, did you have any question, doctor? You raised a hand.
No, after the previous discussion, I'm clear now. Thank you, sir.
Okay, thank you, doctor. So this is how the CCCA is explained. Why I have discussed this, now you will get it understand. So in the PCS exam, at each examiner hand, they will have one particular mark sheet. And they are allowed to provide the doctors at best 14 marks. There are total 28 marks, but each of the examiner is allowed to provide 14 marks at best. They cannot provide you more than 14 marks. Now, how the 14 marks are divided according to each skill. If you notice for each skill, there are 3 segments. One is satisfactory, another is borderline, another is unsatisfactory. Satisfactory means you have got 2 marks. Then borderline means you have got 1 mark. And unsatisfactory means it is 0. Please, doctor, I request every doctors to make some concentration of this part, because this is one of the most important thing. And if you, once you understand the conception of this mark sheet, after completion of this course, you will not need anyone else. So satisfactory means 2 mark, borderline means 1 mark, and unsatisfactory means 0 mark. In this way, all the 7 skills, if you get satisfactory, you will get 7 into 2, that is 14 marks. That is how the marks are given. So let's start discussing one by one skill. Let's start from the physical examination. In the physical examination, if the examiner thinks that he is satisfied with the physical examination, then you will get satisfactory, that is 2 marks. And if you follow the format of CCCA, you will never ever miss any important physical examination. And if you follow it, you will get satisfactory, that is 2 marks. And also I want to provide the information to the doctors that in the real exam, actually the central memory, I call it central memory, it really works. We have to develop the muscle memory beforehand. So we have to know what examination we have to do if particular scenarios comes in the exam. In this course, I have tried myself my level best to format this approach. Like for each particular cases of the 250 cases, I have provided the physical examination recording. And you have to make it identify how the physical examination has to be done, and you have to make it note yourself. And this note will be with you up to your exam. And after making the notes, you have to practice it. After practicing, your muscle memory or peripheral memory will develop. And in the real exam, you will be able to perform without any hesitation. And this is proven truth. This course is being run from third date. And all of you will be happy to know that in the third date, among 12 active candidates, 10 have passed in the basis exam. And the rest of the 2 candidates, they have got wonderful mark in the SSC station. They were very much serious. They did the practice regularly. They made their notes, and they were very much wonderful. Some of them was just started this session for the first time. They were not having any idea about the LCC. But after getting the seat, they had just enrolled for these courses. And with this 1.5 months of dedication, they have passed the exam. So you have to make it earlier of yourself that what are the physical examination you have to do if the case comes in the basis exam. And there is very much high chance that among the 250 cases, you may get 2 of your cases common in the basis exam. This is very much highly likely. So again, let me come back to the mark sheet. That in the physical examination, if you follow this CCCA format, you'll get satisfactory. If you miss any particular thing, if the examiner is not that much satisfied, he may give you borderline, that is 1 mark. If it is unsatisfactory, it is 0. And why it is unsatisfactory, it will be written here. Then come to the identifying physical signs. Regarding the identifying physical signs, let me tell you one important thing. There is a particular thing we have to know for basis exam. That is, omitting is better than committing. This is my dialogue, that is, omitting is better than committing. Why this is important? Because in the basis exam, they extremely dislike synthesizing any positive physical finding. It is extremely disliked. Like for some cases, you may be able to make out some wonderful physical findings, some 5 to 6 positive physical findings. Even after that, if you synthesize one physical finding that is not there, automatically your mark in this identifying physical signs will become unsatisfactory. Only for synthesizing one physical finding. This is that much important. That is why my suggestion to all the doctors will be never tell any physical findings unless you are 100% confident. Otherwise, if you synthesize any positive finding, automatically the mark in identifying physical signs will become unsatisfactory. It is 100% sure. That is why omitting is better than committing for basis exam. We can omit something, but committing anything will make our mark 0 in this particular skill. Another important thing is that in the basis exam, there are 2 types of cases. One is dummy, another one is real. Dummy means sometimes a medical student or a nurse is given. Most of the time, these are acute cases. In the basis exam, there are 2 types of scenarios. One is acute scenario, another one is stable scenario. Most of the time, the acute scenarios are dummy cases. Sometimes one of the case can be real. Sometimes both of the cases can be dummy. The real case can be like systemic sclerosis, a real systemic sclerosis patient, a real Parkinson's disease patient, a real myasthenia gravis patient. This can be real patient. But dummy patient can be also there. Suppose this is a very much popular case in the basis exam for many center, that is hematemesis. Sometimes a medical student is given there. He will tell you that I have taken some painkiller because recently I got injured during playing football. But with this painkiller, I have forgotten to take the tummy protective medication, that is PPI. And from today's morning, I'm having 5 to 6 episodes of blood vomiting. So this is very much simple. Why I'm telling this? This is a dummy case. So from our clinical sense, we can assume that anyone having 4 to 5 times of blood vomiting, he is surely having anemia. So if this medical student really had this 4 to 5 episodes of vomiting, he is supposed to have this anemia, isn't it, doctor? But whenever you are going to examine him, you will never find any anemia there because he is a dummy case. And in the exam, you will automatically understand whether it is dummy or real. You will never find any anemia for this patient. So why I am discussing this thing? Suppose your diagnosis is hematemesis, that is massive blood vomiting due to peptic ulcer disease. And to match your diagnosis, in the identifying physical signs, you have mentioned that I have got anemia. If you mention this thing, automatically your mark will become 0. That is unsatisfactory because of synthesizing finding. Whatever you have got, you have to tell this in truth manner. You cannot synthesize any finding, especially this is important for dummy case. In dummy case, for any acute case, never ever you will get any positive physical findings for that acute case. Like pulmonary embolism is a very much popular case for basis exam with the prompt of chest pain. But never ever you will get any positive physical findings that goes in favor of pulmonary embolism, like raised JVP, loud P2. These things you will never ever get because in the basis exam, they will never give any real pulmonary embolism patient. This thing has to be understood by every doctors. May I know if this conception is clear to all the doctors? How the identifying physical signs is assessed and how the dummy case is assessed? Dr. Saiful is clear. Dr. Mushfika, may I know if this is clear to you?
Yes, sir.
Okay. Please, doctor, please be sure about this skill because what I have seen from my experience that some candidates are very much clinically efficient. They're so much efficient that sometimes they synthesize some finding. And they fall into this trap. automatically the mark becomes 0 in identifying physical signs. So here we have discussed the identifying physical sign skill. The next skill is clinical communication skill. And this part of skill takes a lot of effort. This skill assesses how you are taking the history from the patient, how you are ruling out the differential diagnosis, whether you are taking every part of history taking, whether you are doing important safety netting, whether you are providing necessary support in the form of occupational health worker or social support. Sometimes you may be needed to provide sick leave to the patient. And all this will be assessed in this clinical communication skill. And in this course, we particularly give you training for this skill because these skills needs a lot of effort. And most of the candidates find themselves difficult in being efficient in this skill. Let me discuss to you history taking first, how to take the history for a particular prompt or particular scenario. So this PDF will be provided to all the participants. Don't worry. This PDF will be with you. So this is a simple flowchart of history taking. In the PACES exam, first after entering the station, there will be one of the examiner who will welcome us from the door. Will be provided 5 minutes outside the room. In this 5 minutes, we can make some necessary note, like what are the differential diagnoses we have to think, and many other things. This will be trained to you. This will be given training to all of the doctors during our whole course. So first, we have to do the introduction. After entering the station, we have to do the introduction to the patient. Then we have to do the symptom analysis. How to do this, I'm going to discuss later on. Then we have to do the systemic review. Then we have to take the history of PDF, Sajid, 5P, and POET. Don't worry, all of this will be elaborated. Then we have to do the examination, and we have to do we have to meet the consent. And all of these things will have to be completed by 15 minutes. Right after 30 minutes, the examiner will give you a signal that you have 2 minutes left. And I will suggest every doctor to keep these 2 minutes only to meet the consent. Because sometimes the patient can have multiple consent. These are very much easy to meet consent, like why I'm having this problem. Do I need admission? Do I have cancer? There are silly information we have to provide to the examiner. And this will carry a lot of mark. That is why I'll suggest every doctor to complete all these things with this 13 minutes and keep the last 2 minutes for meeting the consent. And this will become automatically a reflex to all of the doctors if you do regular practice. Every day, I will provide you a lot of homework, and you have to do the homework yourself and also have to practice, and you have to report me every single day. And I'm sorry to inform you that every day, I will personally knock every active candidate to see whether they are practicing or not. And you have to do this practice during this whole course period, during this 5 weeks and 5.5 week period. And this is my guarantee that if you follow this approach, after the 6 to 7 session, automatically you'll see your improvement. You can make it conform to any previous course participant. So let me discuss the introduction first. How to do the introduction? So, sorry. So what does, before the introduction, let me tell you what does this PDF Sajid means. PDF means past medical history, drug history, family history. Sajid means smoking, alcohol, job, impact on daily life, and driving. This is very much important. We cannot miss any part of PDF and Sajid. If we miss any particular part, automatically our mark will be reduced in clinical communication skill. Then 5P has to be taken if the patient is in reproductive age. 5P means pill, period, pregnancy, abortion, I call it abortion to make it remembered for the sake of the mnemonic, then partner. And before asking this 5P, we have to say sorry to the patient that I'm sorry to ask you some personal question. Is that okay with you? And Sajid is not a personal question because for UK, smoking alcohol is very much normal to them. We have to ask about the job. We have to ask about the impact on daily life. This is very much important. We have to ask about the not only impact on daily life, we have to ask about impact on job and daily life. At last, we have to tell about the driving. Regarding driving, many candidates face some problem, like whether we have to stop the driving or not. Let me give you a simple way to meet this concern. In the PACES exam, not in the PACES exam, in the UK scenario, all of the time we'll get some support. Like for assessment of driving, for making the necessary, for providing the necessary information, there's a separate department called DVLA. So they will provide you all kind of support. Why I'm telling this? Because we are having some misconception that we have to make it memorize, that for every symptom, how long the patient has to stop driving, we have to make it memorize. Like for seizure, for how long the patient cannot drive. For myocardial infarction, how long the patient cannot drive. So I will suggest you that this is not necessary at all. Because we just have to tell the patient, stop driving and contact DVLA. That's our job. Sometimes, even if we are not sure that we have to stop the driving, even on that, we can tell the patient that stop driving till further assessment. By telling this thing, you are not telling the patient to drive or not to drive, because this setting is not the final session. After taking the history and all that in the investigation, right after the investigation report comes, you have to sit with the patient again. So you can meet the concern later on. Right now, you can mention like stop driving till further assessment, and this will save you back. May I know if this thing is clear to all? Because many candidates spend their time like memorizing a lot of things, the DVLA rules, and this is not needed at all. We can mention that for every scenario, stop driving till further assessment. By mentioning this line, we are telling the patient, we are not telling the patient to drive, neither to stop driving. We are telling it to stop it a while until the test results are available. Is this clear to all the doctors? Okay. So this goes for Sajid. Another thing is POET. This POET is important only for 4 prompts. That is cough, diarrhea, fever, and joint pain. Here POETs go for pet contact, occupation, exposure, that is sexual exposure, casual sexual contact, and travel history. I will assure you that apart from these 4 prompts, that is cough, diarrhea, fever, and joint pain, for no other case, this POET is important. You don't have to take the history of POET for no other prompt, only for this 4 prompt. And how this case is important, like one time a case of cough come, and in the past, the patient was a pigeon lover. So automatically you can get it, understand that it's case of hypersensitivity pneumonitis, because there is a history of pet contact. One time it came that the patient is a painter. The prompt is cough. Again, this is a case of hypersensitivity pneumonitis. For diarrhea, casual sexual contact is very much important, because one of the important differential diagnosis of loose motion is HIV. Also, we have to take the travel history. So in short, you will get it understand once we discuss the scenario, once we discuss the approach to each particular prompt, how to take history for cough, how to take history for diarrhea, what are the differential diagnoses we have to rule out. You will make it understand that why this POET is important for that particular prompt. And the 4 prompt for which you have to take the history of POET are the cough, diarrhea, fever, and joint pain. So this is all the elaboration of PDF, POET, Sajid, and 5P. And for driving, we can stop the driving till further assessment for every patient. So let's start how to tell the introduction. So right after entering the station, I suggest every doctor to have some smart look, to keep a good smile, because this will give a positive vibe to the examiner that you are smart and you are confident. With a smiling face, tell the patient that your surname. Like my surname is De. So, hello sir, I am Dr. De, one of the doctors working here today. Try to put a smiley face. This will provide a signal, subconscious signal to the examiner that you are confident and professional, because they like the smart and confident examinee most. That is why in your day-to-day case, you see that some of the candidates, they are not clinically so much efficient, but they easily pass this exam with their very first attempt. What makes them different? The difference is that they are very much confident and they are very much communicative. That is why always try to put a smiley face whenever you are doing the greetings with the patient. So this is our first line, that hello sir, I'm Dr. De, one of the doctors working here today. Try to put a smiley face. Then tell your agenda that I'm here to talk with you about your problem and examine you. Is that okay? This line is also important. All the lines are important because we have to take the permission. In the PACES exam, you are not allowed to take any history, not even touch the patient without taking the permission. If you do this way, it is unprofessional. The examiner will think that it is unprofessional. So even before touching the patient's face, looking for anemia, I will suggest the doctor to take permission that I'm going to touch your face. Is that okay with you? This will make you more professional and also provide the signal to the examiner that you are a professional doctor. Then also tell the patient that if at any point of you have a question, please feel free to interrupt me anytime. So this is giving signal that you're very much communicative with the patient. You're very much patient oriented. Then confidentiality is a major issue for United Kingdom. We have to ensure that. In the PACES exam, we'll be allowed to take a paper and a pen with us inside. That will be provided outside. During the 5-minute session, when we are sitting outside the station, we'll be provided with a blank paper and pencil. And whatever we are writing at that paper and pencil, we'll be allowed to take it inside. So we have to tell the patient that whatever we are writing here, it will remain confidential. To provide this information to the patient, we have to mention this line, that I may take a few notes during our conversation, but rest assured, everything will remain confidential. That what am I writing, it will remain confidential. But actually, these things are acting. We have to do this acting multiple times. Then we have to ask the patient about their symptoms. Like, so in your own word, could you please tell me what brings you here today? This particular question is important. Because why this is important? Sometimes, most of the cases will be given a prompt like swallowing difficulty, vision problem, or double vision or headache. So these are the particular prompt. If we ask about that particular prompt, that so in your word or own word, can you please tell me what about your vision problem? This will become closed question. In the PACES exam, we'll try to avoid this closed question because most of the time, the surrogates are very much helpful. And if you ask this open question that what brings you here today, most of the time, they will try to provide you more information than needed. That will help you to get your diagnosis. But if you ask that closed question that from your notes, I have come to know that you are having headache, please tell me more about this. This will become more close and the surrogate will not be able to provide you much information, even if he is willing to do so. So please, doctor, don't go for any closed question. Rather, ask the open question that what brings you here today? So this is the introduction. So may I know if anyone is having any kind of question regarding the introduction part? Or if it is clear, please give a thumbs up reaction so that I can proceed forward, because I have something interesting to discuss later on. Okay, Dr. Saiful is clear. Any other is clear? Okay. Then Right after that, we have to do the symptom analysis. Symptom is the given prompt. So how to analyze the symptom? We can analyze the symptom using the mnemonic ODPARA. Here O goes for onset, D goes for duration, I goes for initial episode, P goes for progression, A goes for aggravating factor, R goes for relieving factor, and A goes for associated feature. So for the onset, we have to ask whether this is sudden onset or gradual onset. For the duration, we have to ask for how long you are having this symptom. For I, we have to ask, is it the first step or whether it is occurring multiple times? Like in the history, she has similar attack beforehand. Then for progression, we have to ask, do you think your symptom is gradually worsening day by day? For aggravating factor and relieving factor, we can just ask anything increase or decrease your symptom. And for all the prompts, associated features will be asked in the screening question. So it has not to be asked separately. So this goes for ODPARA. And we can use this ODPARA for most of the prompt. But there are certain prompts where this ODPARA will not fit. And for that certain prompts, how to do the symptom analysis in this course will give you a written set of questions, like how to do the symptom analysis for that particular point will provide you in organized way how to do this. You'll get it once the course starts. So this is for any kind of symptom or ODPARA. Then, if the prompt is pain, for that particular pain, we have to analyze that pain. For analyzing the pain, we use a different kind of mnemonic, that is liquor. Liquor is a type of alcoholic drink. It is called liquor. You can also use the Socrates or anything else. That is your personal choice. It is wonderful. Or you can go with this liquor. So what goes for liquor? But before starting for liquor, let me tell you that for any kind of pain, specifically if it is mechanical, take the history of trauma first. Ask the patient, is there any history of injury? Then start the liquor. Here L goes for location, I goes for intensity, Q goes for quality, and R goes for radiation. For the location, we have to ask, where do you feel the pain exactly? This is very much important question. Let me give an example. At one time, a case came at Pondicherry. The prompt was low back pain. So from outside, everyone was thinking that this is a case of musculoskeletal pain. But after entering the station, whenever this question was asked, that where do you feel the pain exactly? She was a lady. She was showing her renal angle. So that thing completely changed the diagnosis. That was a case of pyelonephritis. She was taking a medication called SGLT2 inhibitor. You'll get this case to practice in your PDF cases. That is why every time we have to ask this location that where do you feel the pain exactly? Then I goes for intensity. We have to ask the patient how severe the pain is, 1 being the lowest and 10 being the highest. And for any type of pain, I will suggest the doctors to provide painkiller. Because the patient, specifically if the pain is more than 4 to 5, better to ask the patient, do you need any painkiller? Because we have to manage the pain. And these will provide a subconscious signal to the examiner that you are a safe doctor, you are a sympathetic doctor. And these will ensure your mark in clinical communication skill. Particularly if the pain is more than 7 or 8, if you don't provide painkiller, these will affect your mark in this skill of clinical communication. So doctor, please provide painkiller for all type of pain. Then Q goes for quality or nature. We have to ask, what sort of pain is it? Can you describe it for me? Is it dull pain or crampy pain or dull pain or crampy pain or shooting pain? What type of pain is it? Then R goes for radiation. After starting from here, does it go anywhere else? So this is all about pain and this is all about ODPARA called symptom analysis. So right after doing the symptom analysis, we can go to the systemic review. So doctors, I will request every doctors to be concentrated on this discussion, because right now I'm going to provide you a particular trick that will help you most in the basis exam. So what is that trick? The trick is that in the traditional way, after introduction, then we have to do the symptom analysis, then we'll start the systemic review. But I will suggest you that after symptom analysis, directly ask the past medical history, drug history, and family history. That is PDF. And this is my guarantee that in 90% of the cases in the basis exam, you will get your diagnosis beforehand. If you go to the PDF earlier, this is my 100% guarantee that in 90% of your basis exam case, you can make it, you can match it in a real day-to-day practice. If you directly go through the past medical history, drug history, and family history, right after symptom analysis, you'll get your diagnosis and it will become very much cool. Let me give you some real basis case example. Right now, I would like to have some interaction with the candidate. This is a interactive session. Sorry. Right. I would like to see who can catch the diagnosis. Right now, I'm going to discuss some real basis cases. So at one time at Bangalore, this case came 2.5 years back. Sorry. Okay. Yeah. The prompt was fever. I talked to this candidate who appeared at this exam personally. So the prompt was fever. He was having fever. After entering the station, he was telling that he is having fever for last 1 month. And there was nothing else positive in that. He was not getting any source of fever. There is no respiratory tract infection, no respiratory tract symptom, no urinary tract symptom, no GIT symptoms. Nothing was there. Even he was asking all the past medical history that do you have any past medical condition that I should be aware of? Any family history, any drug history? Nothing else was there. Right before completing the examination, like in the physical examination, on top of that, there is no positive physical finding. But whenever he was asking, just before the ending of the examination, whenever there was 2 minutes left, he was asking any recent procedure. Right after that, the patient replied that 1.5 months back, I had a dental procedure. So after getting this information, can anyone tell what should be the diagnosis? Just unmute yourself and you can tell your diagnosis.
Infective endocarditis.
Yes, doctor, infective endocarditis. Dr. Sana has also given the right answer. This is a case of infective endocarditis. And he was not having any valve replacement also. This was a native valve. Only the history was any recent procedure. Why I am telling this? Because also in the past medical history, we have to know what question we have to ask. And in this course, in this PDF, we'll provide you this thing in written format. Like in the past medical history, I will suggest every doctor to ask all these 8 questions, because you cannot imagine from which question the diagnosis can come out. He was asking all these questions that do you have any past medical condition that I should be aware of? He denied. Any surgery before? He denied. Any hospitalization before? He denied. Whenever he was asking any recent injury, right after that, the diagnosis came out. It was a case of infective endocarditis. It was a dummy case actually. That is why we have not only the thing that, knowing this thing that in the past medical history, drug history, if you ask the PDF earlier, we'll get you our diagnosis. We have to know in the past medical history what particular sets of questions we have to ask. That is why we have to memorize these 8 sets of questions. Please, doctor, please make it remember. Another thing, I'm giving you another example. That happened with myself. During my time, I got a case. The prompt was headache. From outside, it was written that this 35-year-old male, there was a name written there. I have forgotten the name. The information was that this 35-year-old man has come with headache. In the vitals, it was written that the temperature was 38 degrees Fahrenheit. So 38 degrees Celsius. So it was a headache with fever. Simply, it is being revealed that this is a case of meningitis. So after entering the station, I saw that it was a normal appearance male. He was wearing a gown. After getting analysis, after analyzing the headache prompt, I asked, "Do you have any past medical condition that I should be aware of?" Let me go to the screenshot. So I asked him, "Do you have any past medical condition that I should be aware of?" He completely denied. Then I asked him, "Any surgery before?" Right after that, he replied me that 5 years back, I had a road traffic accident. And at that road traffic accident, certain parts inside my tummy has been removed. I then again asked him, "Can you remember the name of the surgery?" He again denied. "I cannot remember." So what I did, I just removed the gown. I just, after taking the permission, I told the surrogate that, "Can I see the tummy?" I saw there was a splenectomy scar. So he was having splenectomy due to road traffic accident. So can anyone tell me that what should be my next question to the patient? I'm getting a splenectomy scar and he has come with headache with fever. What should the next question, doctor? Can anyone guess?
Did he get vaccinated?
Regarding vaccination,
Wonderful, doctor. Vaccination. In the PACES exam, vaccination is actually a jargon. We have to ask about the shots. Yes, Dr. Rafi is wonderfully excellent. Vaccine and antibiotic. So we have to. I asked him that, "Did you take the recommended shots?" He replied that, "No, I could not take it." I asked him why. Then he replied that, "I live in a slum. I don't have the finance to meet that to meet the expense of shot." So he was having financial problem. My job is to refer him to the social worker. I do accordingly. I did accordingly. I referred him to the social worker for financial support. I also asked him that, "Did you take the recommended antibiotic?" He denied for the same reason. I also referred him to the social worker for financial help. So all of you up to now have got it understand what should be the diagnosis here. Can anyone tell it again? Why this headache with fever is occurring here? Any doctor?
Meningitis due to capsular,
Yes, doctor. You are right. Capsulated bacteria.
Capsulated organisms are patient becomes more susceptible to capsulated organisms.
Yes. This was the diagnosis. So right after 2 minutes, I got my diagnosis and I become cool and I got 28 out of 28. And believe me, in the real exam, if you follow this PDF format, that after symptom analysis, if you directly ask the past medical history, drug history and family history, you will get your diagnosis beforehand. And this will ensure your mark. You will become cool-headed, you will become more focused. Let me give you another example. Let me see who can give the diagnosis. This is also a real PACES case. It was a case of 35-year-old female. Sorry, wait. 35-year-old female with hematuria. This was a prompt. This prompt came at the PACES exam. In the past medical history, she gave history of hypertension. In the drug history, she's taking medication for hypertension like losartan. In the family history, she replied that her father died of brain stroke. We all know that anyone having ischemic stroke is less likely to die. So whenever anyone is telling that my father died of brain stroke, it indicates that he was having intracerebral hemorrhage. So from these sets of information, can anyone guess what should be the diagnosis here? What is the cause of
Kidney.
Autosomal
Kidney.
polycystic kidney disease.
Yes, doctor, that was the diagnosis here. That is why PDF is very much important. Again, I have told you that from this course, you will get 90 to 95% case common. Sometimes, if by chance, accidentally, you don't get this prompt common, if you just follow the approach of PDF, 100% time after completing this course, all the prompts will be common in your basis exam. You will get your diagnosis beforehand if you ask this PDF earlier. Let me give you another example. This case has come multiple times. Also in this Diet Dhaka Center, this case has come. This was a breathlessness case with dry cough. She was a 40-year-old female. So in the past medical history, she is a diagnosed case of rheumatoid arthritis. In the drug history, she takes methotrexate. So based on this information only,
Interstitial lung disease.
yes,
ILD.
doctor. ILD. What should be the cause? What are the possible causes of ILD here?
Either drugs or rheumatoid arthritis.
Yes, both.
Either-
Rheumatoid. Yes, doctor. Both can be the possible cause. This was a diagnosis. And this case has come multiple times in the basis exam. Simply this rheumatoid arthritis induced ILD. And you will see after appearing the exam, you'll see that actually candidates means the pass exam not for making a gross mistake. They make the simple mistake. And in the basis exam, these things actually very much unfortunate. Only after getting this case, many candidates will miss the proper mark. Many candidates have got 10 out of 28 for simply this exam because they were thinking something difficult to expect. But this case was that much simple. Let me give you another example, another real basis case. This was a case of hematemesis or blood vomiting. This is also a triple ester case because this case is coming again and again, and any one of you will face this case. In the past medical history, it gives history of hepatitis C. So simply by this information, can you guess the diagnosis?
Esophageal varices.
Yes, doctor.
Esophageal
Sorry.
varices.
Varix rupture. That is why it is that much simple. LCC is very much easy if you know how to approach to the case. Once you unlock the secrets of this basis LCC station, you'll look that this is very much easy because here they are assessing you to enter into the ST3 level. They are not assessing you as a consultant. And I will again request AP doctor, try to follow this PDF format. That is past medical history, drug history, and family history. You will get your diagnosis beforehand. Let me give you the last example. In this whole course scenario, you will get more and more examples. More than 200 examples, like how the PDF will help you in getting the diagnosis. This was a 20-year-old male with collapse. In the neuroprompt, we'll discuss how to approach to a case of collapse. For right now, there is a family history of sudden death. So anyone having loss of consciousness or collapse with a family history of sudden death, what things you have to rule out?
Potassium.
Cardiac.
Hypertrophic
Yes.
cardiomyopathy.
Yes, doctor. Congenital cardiac disease. This can be HOCM. This can be Brugada. This can be long QT syndrome. Anything can be there. That is why I'm again telling past medical history, drug history, and family history. I will tell you these are the blessings for PACES exam. And if you ask this question beforehand, you will get your diagnosis. You can mark my word and you can match this in your real exam. I'm giving you the guarantee, doctor. Also, another important thing is there, in the drug history, you have to ask all these sets of questions because sometimes the surrogate may not be that much helpful. Unless you ask specific question, they will not give you the direct answer. And one of the most sensitive questions of all these questions are the medication allergy. Why this question is important? Because for the UK, allergy to medication is very much sensitive. Let me give you a real example. In DIE 3, at Delhi Center, a case came with loose motion. The candidate who appeared at that exam, he was one of the participants of our LCC batch, one of the 10 candidates out of 12 who passed at the DIE 3 exam. So the diagnosis for that loose motion was infection, IBD, and malignancy. These were the differential diagnoses. But in the drug history, he asked any allergy to any medication. And he was the only candidate at his carousel who asked this question. And whenever this question was asked, the surrogate replied that 5 years back, I had an upper respiratory infection or a bug infection of my chest. Right after that, I was given a medication called penicillin and I had adverse reaction. So that doctor informed me that I am having penicillin allergy. Look at this particular prompt. This penicillin allergy has nothing to do with the real diagnosis of loose motion. But only he was able to identify this penicillin allergy. And this is an important information. That's why I'm asking every doctors not to miss allergy to any medication. So all the other candidates who missed this penicillin allergy lost their mark in clinical communication skill. This allergy has nothing to do with the real diagnosis. Even on top of that, we have to ask the allergy to any medication. This is a must. And from many times, you'll see this example. Also, this happened in DIE 3 at Hyderabad Center. 2 penicillin allergy came, 2 scenario that had nothing to do with the real diagnosis. At DIE 2 exam at Pondicherry, a Chinese lady came as an examiner. I can show you the mark sheet. Only for not asking this allergy to medication, he deducted the mark in clinical communication skill. That is why allergy to any medication is a very much important question. And during our practice session, I try to give this training to every doctors to ask this particular question, that any allergy to any medication. You may not guess what positive information can come out. So these are the drug history and all the things have been written here. You have to ask these particular questions and try to memorize all these 7 sets of questions. This PDF will be provided to all of the active candidates. Also with a listening, that is type 2 and type 3. Then regarding the family history. Family history is also important. For family history, we have to ask any disease running in the family, anyone of the family member having similar problem. 2 questions have to be asked. Then for syncope and palpitation, we have to ask family history of sudden death. This sudden death need not to be asked for any other prompt, like this case of collapse of syncope and palpitation. This needs family history of sudden death. That if the case is goiter, the patient is having neck swelling, the prompt will be neck swelling. After entering the station, you're seeing that she is a case of goiter. We have to ask any family history of gland cancer because there can be medullary thyroid cancer. So that's all for PDF. I'm again telling for PACES exam, this PDF is purely a blessings. I will tell you it's a blessings. So try to use these blessings, doctor. You'll get your diagnosis beforehand. And this will be true for more than 90% of the cases. So this is all for PDF, and let me tell you with flowchart. So right after symptom analysis, I would suggest every doctor to go to PDF, then complete the PDF Sajid 5P as needed. Then you can start the systemic review. In the systemic review, what questions has to be asked from each system? These are written here. You can make it a read. You can ask each system separately, or you can become focused. Like if the prompt is like hematuria, then we have to ask all the renal systemic question must. After asking the renal questions, if you think that you need to ask other system question based on the differential diagnosis, you can go for that, or you can skip also. This is your decision, but this will not affect your mark. But you have to ask that systemic question from where the prompt has been given. Like if the prompt is hematemesis, we have to ask all the gastrointestinal tract system question. After asking this GIT systemic question, we can think of anything else. So after systemic review, we can start the examination, and how to do the examination. This will be given to you in recorded form, and we have to meet the consent. So let me get back to the mark sheet again. So the things we have discussed comprises the clinical communication skill. Also, another thing is there, we have to mention about the safety netting. And safety netting is not needed for every prompt. Safety netting is needed for particular prompt. Like if the prompt is skin rash due to vitiligo, we have to offer sun, we have to tell the patient that avoid sun exposure. If the prompt is hand pain due to carpal tunnel syndrome, we have to do the safety netting of avoid cold exposure. If the prompt is collapse due to seizure, we have to tell the safety netting of the seizure. And all this safety netting will be provided to you during this whole session, during the prompt discussion session. We'll provide to you what specific safety netting we have to keep it in mind for a specific prompt. And this is very much important, because if you miss this safety netting, automatically mark will become borderline. So that actually clinical communication skill is very much sensitive, because anything you miss it, automatically the mark will become lower. And this thing has to be practiced multiple times. And this course is there to help you particularly for this skill. How to take the history, how to rule out a differential diagnosis, how to do the safety netting, what important support we have to offer for each particular prompt. So this is all for safety netting. And if it is satisfactory, the examiner will provide 2, borderline is 1, and unsatisfactory is 0. If it is 0 or borderline, why this is given, it will be written here in details. Sometimes if the space is not enough, they will write all the things here. So in this way, clinical communication skill is assessed. May I ask from the doctors whether anyone is having any kind of confusion or question from this clinical communication skill? Any question, doctor? Please feel free to ask me. Dr. Rubel, may I ask you, do you have any question?
No, bhaiya. It's okay.
Dr. Rafia, any question, doctor? Okay, Dr. Rafia is good. Dr. Monem, any confusion or question?
It's okay. It's going nicely.
Okay, thank you, doctor. So the next skill is differential diagnosis. Here we have to try to tell at least 3 differential diagnoses for a particular prompt. And in this course, for every prompt, we are going to provide you an organized sets of differential diagnoses. That differential diagnosis you can use here to get the full mark in the differential diagnosis. And also try to tell at least 3 differential diagnoses for each particular prompt. Sometimes you may get only 1 differential diagnosis that are different. but try to tell 3 differential diagnosis. Also, another thing is there. Here will give you an organized list of differential diagnoses. But on among the many differential diagnoses, one will become the definitive diagnosis. So we have to mention it as number 1. Then the number 2 and 3, that will not fit for this scenario, but we can mention them as the differential diagnosis. Okay, let me give an example. Then it will become clear to all the doctors. Okay. Suppose our prompt is low back pain. And this is a case of mechanical low back pain. Our diagnosis is discitis. Suppose it's a definitive diagnosis. For this mechanical low back pain, if we discuss the approach to low back pain, we'll discuss it here. These are the differential diagnoses of mechanical low back pain. That is trauma, septic arthritis, osteoporosis, osteoarthritis, metastasis, multiple myeloma, PLID, and psoas syndrome. These are differential diagnoses for the MRCP PACES exam. So if our definitive diagnosis is discitis, we can mention any 2 as the differential diagnosis. That we can mention that this can be a case of trauma. But also we have to mention the points going against that particular differential diagnosis. Like my differential, I have the examiner will ask you, do you have any diagnosis or differential diagnosis? We have to reply that I have some differential diagnosis. My first differential diagnosis is discitis. By another differential diagnosis, it can be a case of trauma, but against that, from the history, I have not got any history of injury. This can be a case of metastasis, but against that, from the history, I have not got any history of malignancy. This can be a case of osteoporosis, but from the history and physical examination, I have not got anything in particular favoring osteoporosis. So what I want to tell you that in the differential diagnosis, after telling the basic diagnosis, the main diagnosis, we have to mention 2 other, but also we have to tell what goes against that particular differential diagnosis. If you approach it this way, you will get satisfactory in differential diagnosis mark. But there is one important thing I want to mention for this differential diagnosis. What is this? Let me tell you. In the PACES exam, usually the examiner are not that much sensitive regarding the order of differential diagnosis, like which thing we have to tell first, which thing we have to tell in the second, which thing we have to tell in the third. Like there are certain differential diagnoses like loose motion. You can follow any order, except one prompt. What is that prompt? The prompt is chest pain. If anytime any chest pain comes in the MRCP PACES exam, in more than 90% of the cases, it will be pulmonary embolism. Please make it remember. It is very much important because if you don't mention the pulmonary embolism as number 1 here in the differential diagnosis, automatically you lose your mark. For this particular prompt of chest pain with pulmonary embolism, I'm telling it from my personal experience because I passed my PACES exam at my second attempt. During my first attempt, I appeared at Bangalore Center. There, I got this chest pain prompt. I was given a lady. She was a dummy case. She was a nurse working there. She was 40 years old. My prompt was chest pain. And she was telling that I'm admitted into the hospital for the last 3 days. I'm a diagnosed case of COPD. I was able to get discharged, but right before getting discharged, I'm having some chest pain. She was showing that she was having the chest pain at the left side of her chest. So in our day-to-day practice, in our subcontinent, we are usually habituated to see any COPD patient coming with chest pain. The most common diagnosis is pneumothorax or acute coronary syndrome. So I mentioned my first differential diagnosis named acute coronary syndrome. Second is I want to rule out pneumothorax. In the third, I mentioned pulmonary embolism. This was my order of differential diagnosis. Because she was admitted into the hospital for 3 days. She was a dummy case. She was a case of pulmonary embolism, and she was talking to me in happy face. This is how the case comes in the physics exam, the acute cases. This was a dummy case. So after getting the feedback, what I saw, one of the examiner gave me unsatisfactory, another examiner gave me borderline. And I missed my pass mark only by 1 in the differential diagnosis. That is why I request every doctor to make this remember that anytime any chest pain comes in the PCS exam, it will be pulmonary embolism for more than 90% of the cases. Look for the clue. After ruling out all the clues, then approach for any other cause. And how to look for the clue? There are 9 clotting questions. I will give it, I will provide it in written form during discussion of our cardiovascular problem, the approach to chest pain. After asking this 9 clotting question, if you don't get any positive history, then you can exclude the pulmonary embolism. But from the 9 clotting question, if you get anything positive, please mention the pulmonary embolism as your number 1 DD. Otherwise, it will become unsatisfactory for sure. May I know if this message is clear to all the doctors? Because this is very much important to know. Only by for not knowing this thing, I had to appear at the PCS exam twice. So after learning this thing, I talked to many UK doctors, and I have found that pulmonary embolism is very much common in United Kingdom. That is why they are very much sensitive. And pulmonary embolism is a triple star case. Right before appearing the exam, I did not know this thing, that if any chest pain comes in the PCS exam, the pulmonary embolism should be the 1 differential diagnosis. And they are very much sensitive regarding this pulmonary embolism. So doctor, please make it remember. So this goes the differential diagnosis. There goes. Then come to the clinical judgment. So what things are asked in the clinical judgment? After we complete our examination, the examiner will ask only 4 sets of questions. That is, do you have any diagnosis or differential diagnosis? To provide us mark in the differential diagnosis section. The next question will be, what are the positive physical findings? To determine our mark in identifying physical signs. And the good news is that in the PCS exam, we don't have to organize how to present my case. They don't bother about it. And they don't want to hear the negative findings. Like there is no evidence of pulmonary hypertension, no evidence of JVP. They don't want to hear it. Even if you tell it, they will make you stop. They will tell you that, doctor, don't waste my time. Tell me only the positive physical findings. So that will dictate your mark in identifying physical signs. Then they will ask you how to investigate and how to manage. And believe me, if you can tell this investigation and management in professional way, you will get full mark in clinical judgment. You don't have to know a lot of theoretical knowledge. Only you have to know what are the investigation you have to mention and how to tell the management. Regarding management, regarding investigation management, all of these things will be provided to all of the candidates of type 1 and type 2 in recorded form for each cases of the 250 cases. But I want to mention it here that, in the PCS exam, 2 types of scenarios come. One is acute. Another one is stable. Regarding this stable case, during management, we have to start with first education and counseling, then forming a multidisciplinary team, then treatment of the underlying cause, and treatment of complication. This is very much simple. they will hear from you, they will want to hear from you whether you are educating the patient, whether you are forming the multidisciplinary, because this is our task there. They are not there to judge our clinical knowledge. Then if the case is acute, the initial part will be admission. We have to tell that we'll admit the patient. Then we have to mention about the management of airway, breathing, and circulation. Right after that, we have to proceed with education and counseling, forming a multidisciplinary team. Then treatment of the underlying cause, treatment of the complication. If you follow this approach, you will get full mark in the management. And believe me, this thing is so much simple that sometimes many candidates make mistakes here. For acute case, they forget to tell the admission, they forget to tell the airway, breathing, and circulation, because they expect that the examiner is going to ask from me some difficult question, where they just want to hear from you whether you are managing the airway, breathing, and circulation, and that's all. This is very much simple, but only for thinking critically, candidates tell something different. They expect some difficult question. So this is how the management has to be told, and all these things will be provided to you in the record. Then come to the investigation. Already in the investigation, how to follow the CCCA format have been discussed. But I want to mention an important thing. All the doctors will be able, what are the investigation we have to do for that particular case? Because all of the doctors, we already have passed the MRCP part 1 and part 2. And we have come to know a lot of theoretical information. But in the real exam, simple things will be missed. And that is missed. The simple thing is, maximum candidate forget to tell this simple word. That is apart from basic investigation. For every case in the United Kingdom, we have to do the basic investigation first. So only for not mentioning, apart from basic investigation, marks are reduced. If you notice, if you get any chance to look any feedback of real PCS exam, you can notice that many candidates forget to mention about this basic investigation, and the marks are reduced. Then after coming from the exam, they try to synthesize some fairy tale that my exam was very much difficult. He was asking me a lot of questions. That is actually basically not true. Also, on top of that, there is another tricks. We have to spend a lot of time with the examiner. Like this is after 15 minutes, there are 5 minutes left with the examiner. So we have to follow a particular trick to guide the examiner. The trick is we don't have to reply any answer in a hurry. Because if we complete all these answers, like investigation and management in professional manner, surely he will give us full mark. But to pass the time, he will not stop there. He will continue asking some other question. He will take you from Nepal to the Bhutan, from Bhutan to the Myanmar, from Myanmar to the Singapore. Anywhere they will take you. They will continue asking any type of question. And you will think that he is asking you some different question. But this is not true. They have already judged you by asking the investigation and management, and the rest of the things are being asked only to pass the time, to see your confidence. That will not affect your time. But what is the negative side of that? The negative side is that whenever you are asked some difficult questions, like what is the study report, what are the eco findings? So if you are not able to answer that particular questions, you may feel some stress inside. That will affect the next session. But after getting the feedback, after the results are released, you will see that you have got full mark at that station that you are tensed most about. And this will happen for every time. That is why in the PCS exam, the candidates, for that particular station, the candidates think that I have made some blunder, they get good mark there. But this tension will affect your next stations. So how to cope up with this? The technique is that don't give all the answers in one go. Let the examiner ask the question and keep the answer in slow pace to cover this 5 minutes. Like there are some wonderful smart candidates. Whenever before asking the question, they will give the answer, and they will dig their own grave. Because if you complete answering all the questions in 2 minutes, the rest 3 minutes you have to pass with the examiner, and he is going to ask you many questions that will make you nervous for the next session. So you have to tell him, go in slow manner. You have to tell the patient, like in the investigation, we have to mention that apart from basic investigation in the form of complete blood count, serum, electrolyte, renal function test, liver function test, and that's all. To confirm my diagnosis, I will do this. And try to tell this thing in slow manner. Don't jump and don't do hurry. Because if you do hurry, and if you complete it beforehand, the examiner is going to ask you another question. Then, regarding the management, sometimes you will have some differential diagnosis. So, to kill your time of 5 minutes, there's another trick. After mentioning the educational counseling from a multidisciplinary team, tell the treatment of the underlying cause. Then keep silent. Let the examiner ask. The examiner will ask you, suppose the underlying cause is infection. What will be treatment? Suppose the underlying cause is IBD. What will be treatment? Let the examiner invite the question. Don't give the answer beforehand. I know, or all of us know, that you know a lot, but this exam is a tricky exam. And to guide the examiner in your way, don't tell extra thing and don't do the hurry. Whatever you know, just follow the simple approach and tell it in slow manner. And believe me, you can match this finding. If you're able to tell the investigation and management in proper way, you will get the full mark in this clinical judgment. Because clinical judgment is assessed whether we are being able to stabilize the patient, whether we are able to order the appropriate investigation, whether we are able to do the management in the form of multidisciplinarity. That is why I will suggest every doctor to follow this particular trick and nothing else. A lot of information has to be known for this physics exam. Only you have to know the investigation and management in particular. And during our whole practice session, I'll try to provide the training to all the doctors how to tell the investigation and management in slow manner to kill this 5 minutes time. So may I know if this is clear to all the doctors? And why physics exam does not need a lot of theoretical knowledge to pass? Okay, Dr. Ashik is clear. Dr. Jahid, are you clear?
Yes, sir.
Okay. Dr. Rafia, are you clear?
Yeah.
And also, I will request every doctors to make notes of this investigation and management. For that particular case, that will be provided to you after this session. So in this way, you have to make notes of almost 250 cases. Sorry, 250 cases of investigation and management. And these notes will stay with you up to the exam. And in the recording, you will follow the guidance. You'll get the guidance, how to tell the investigation and management for that particular scenario. So this is all for clinical judgment. The next thing is managing patient consent. So already I have told you that after 13 minutes, you have to keep at hand at least 2 minutes to meet the consent. Because sometimes the surrogate will stand there with a written, with a paper at their hand. And there you can find at best 6 consent. Unless you meet all the consent, you will not get full mark in this managing patient consent. And this thing has to be explained without using any jargon. It's not that much difficult. It is very much easy. Once you start practicing, you will make it out. These things only needs a little amount of practice, nothing else. You have to make it understand to the patient without using any jargon. That's all. It is very much easy. It needs a little bit of practice. And this in this whole session, the whole case, you will be given the training of how to manage the consent. The last thing is maintaining patient welfare. In this welfare section, it is very much easy to get the full mark. That is 32 out of 32. Just you have to make sure that you are not causing any pain to the patient. And also try to follow some approach, like after completing the examination, try to tell the patient thank you. If possible, try to tell it 3 times. That is, thank you, sir. Thank you very much. You have done wonderful job for me. Try to tell this thing by doing handshaking to the patient. If you do this thing, this will give a positive vibe to the examiner. And also try to help the patient to put on his gown. Whenever you will try to help the patient to put on the gown, right after that, the surrogate will come and take the job from your hand. But you have to offer that. And truly speaking, the first section is very much narrow for this maintaining welfare. That is, you have to get 28 out of 32. This welfare is there for every station. If you don't get 28 out of 32, you'll get failed in managing patient welfare. And if you're not able to score 28, suppose you have scored 27, what is the drawback of this mark? You will not be given C for the next diet also. This is done by RCP. I'm again telling, if anyone gets 27 out of 32 instead of 28, the RCP will not provide seat for PACES exam for the next diet also. That is why don't cause any pain to the patient. Treat him like a VIP. And also try to provide thank you multiple times to the patient. And most of the time, most of the candidates get 32 out of 32. Yeah. This is very much easy. Just be a professional and do the practice. Also try to follow the practice in day-to-day life. So this is all about this mark sheet, and each examiner has 14 marks for the 7 skills. The marks from both the examiner in total are 28. And these are marked separately with 2 different mark sheets, 2 different feedback. So may I ask if there is any question from this mark sheet? Because in this whole course session, you will face this thing multiple times. And after completion of this course, I want every doctors to become like a mentor. And you will get it. If you talk to any other previous candidate, you will get it that this thing is is given training multiple times in this course. And also during your day-to-day practice, like whenever you will be provided the homework, we have to use this mark sheet while practicing with other participants. We have to act like an examiner. Also, you have to act like an examiner. And you have to provide mark to other candidate, that is the active participant, using this mark sheet. If you approach this way, after that, you will be able to understand that how the marks are given in the PACES exam, what the examiners wants to hear from us. So, may I know if there's any confusion or question from any doctors? Any question, doctor, from this mark sheet?
I had a question regarding the last one, maintaining patient welfare. Well, it's mentioned that the marking is done satisfactory, borderline, and unsatisfactory. So
yes,
but it is also, you also mentioned that it is marked from 32. Like if I get below 28, that so actually what happens? When do I get unsatisfactory? Do I get it when I get 28, or I didn't really understand the marking.
Okay. I got your point. Actually, PACES exam, pass or fail does not depend on particular station. It depends on the skill. And the whole PACES exam will be assessed based on the skill. And this LCC is only the one station where all the 7 skills are being assessed. Whenever we'll get the mark sheet, we'll see that our results are given based on the skill of each, based on the mark on each skill. So sometimes you can see that it has happened. A candidate has got 145. This is a very much good mark. On top of that, he has failed. Why he has failed? He has failed in any of the skills here. So here we are assessed based on the skill, and not all the station will assess all the skills. Only the LCC will assess all the 7 skills required for basis exam. And for this maintaining welfare will be there for each station. So there are 5 stations. Let me get back to you. These are the 5 stations. And station 1 will face respiratory and communication station. Inside respiratory, there will be a separate section of maintaining patient welfare. Inside communication, there will be a separate skill section of maintaining patient welfare. Then in the station 2, in clinical consultation, there's already a section of welfare. In this way, this will be there for every station. Are you getting it, Dr. Saiful?
Yes, yes.
So this welfare maintenance is assessed at each station. And why this skill is being assessed? Here they assess whether you are a safe doctor, whether you are causing any harm or you are causing any pain to the patient. That is the reason. Before touching the patient, we have to take permission. If the patient is complaining of tummy pain, before examining the tummy, we have to ask the patient, patient is feeling pain, should I proceed? We have to ask the patient also that do you feel pain during our examination? If you feel any kind of pain, please feel free to stop me at that moment. And whenever you are checking the gait of the patient, please give support to the patient. Because if the patient anytime falls, be sure that you have lost your mark in welfare. And if it is failed, you will not get sick for the next diet also. But most of the time, the candidate get full mark in maintaining patient welfare, except few candidates. There are some candidates who are clinically very much sound, but they are not very much sympathetic to the patient. And that things also happen with the real exam. They, by checking their approach, the examiner becomes a little bit dissatisfied. Like they are not very much empathetic. They do the handling in a rough manner. May I know, Dr. Saiful, is this clear to you?
Yes, it's.
Any other question, Doctor? Please ask me, Dr. Saiful. I think you still have some confusion.
Actually, regarding this, you said if I get below 28, then
yes.
Yes. But does it apply to only if I fail in only one station? I mean, in one station, then it is sufficient.
Even if you fail at one station, your result will be fail.
Okay.
For getting pass mark, you have to pass for each station, each skill separately. So even if you fail at one skill, the result will be fail. Did you get it now, Doctor?
Yeah. Okay. Thank you.
Okay. So this is all about mark sheet. We are almost at the end of our introduction session. The next thing is that I want to mention. There are particular things we have to know about the travel history whenever this is positive there. And what in the travel history, what we have to know before travel, during, and after, it is written there. You can cover it from the PDF. And another thing is there, the diabetes questionnaire. These things candidate face difficulty. Whenever in the basis exam, we see any long-term diabetic patient, specifically more than 10 years, we have to ask this diabetic questionnaire. What are the questions? First, we have to ask some general question that we have a high blood sugar for how long? How was it diagnosed? Is it routine blood test or by some emergencies? We all know that diabetic ketoacidosis is diagnosed, type 1 diabetes is diagnosed by an emergency of diabetic ketoacidosis. So this question has to be asked. Then what medication are you taking? Do you go to your eye doctor, kidney doctor, and food doctor at regular interval? Then also offer to check the 3 months average blood sugar report, that is HbA1c. So these 5 are the general question. Then we have to look for the compliance of the triple D, that is diet, drug, and daily exercise. We have to ask about the compliance with the medication, compliance with the diabetic diet, compliance with the regular physical exercise. Then from the history, we have to rule out the low blood sugar and high blood sugar common, that is hypoglycemia and HHS or DK, whether there was any episode earlier. Then we have to ask 3 specific complications. One is microvascular complication, another is macrovascular complication, another is autonomic complication. For the microvascular complication, long-term diabetes can affect the peripheral nerve. It can affect the retina. It can also affect the kidney. So these are the microvascular complication of diabetes. That is diabetic neuropathy, diabetic retinopathy, and diabetic nephropathy. We have to ask, do you feel any tingling or numbness at your hands and feet? Ruling out diabetic neuropathy. We have to ask any vision problem. Ruling out diabetic retinopathy. We have to ask, what about your urine? What about the amount, color, frequency, and frothiness? Ruling out diabetic nephropathy. Then we have to rule out the macrovascular complication. The macrovascular complications are three. One is stroke, then heart attack, then peripheral vascular disease. So to rule out the stroke, we have to ask any weakness or previous episode of weakness at any parts of the body. Any chest pain or rest, any chest pain at rest or while walking, ruling out MI or angina. Any pain at the back of your leg while walking, ruling out peripheral vascular disease. Then we have to rule out the autonomic complication. There are 5 questions for autonomic complication. One is postural hypotension. Then there are some questions for diabetic gastroparesis, then erectile dysfunction. To rule out the postural hypotension, we have to ask, do you feel dizzy standing from the sitting position? Then for diabetic gastroparesis, patient feel early satiety. So we have to ask, do you feel full after eating? There can be gustatory sweating, any increased sweating while eating. There can be small intestinal bacterial overgrowth due to diabetic gastroparesis. So we have to ask, what about your bowel habit? Any loose motion, any tight motion in between the loose motion? Because there can be alternative constipation and diarrhea due to the diabetic gastroparesis. Because the peristalsis is not controlled in the proper fashion there. Then any problem in your intimate relationship, that is erectile dysfunction. So this PDF will be provided to the participant, and I suggest to make it remembered, and if possible, please memorize these things. Because in the real exam, candidates often become puzzled asking for the diabetic complication questions. This will be provided to you. And the rheumatology screening question will be discussed during the prompt session today. So this is all for the introductory session. May I know if anyone has any kind of question or confusion from the introduction of the course? Any question from any doctors? Dr. Zia, do you have any question, doctor? Dr. Sana, may I know any question? Okay. So if it is okay, then I would like to start our today's musculoskeletal prompt. But before that, I'd like to take a break of 5 minutes to give some rest to my voice. So doctor, let's meet 5 minutes later on, and the skin will be okay. And we'll start just after 5 minutes from now. We'll start the approach to the musculoskeletal system. Thank you, doctor. See you later, just 5 minutes later. Let me stop the recording now.